this new Chapel Hill classification, which we'll talk about a short while from now. Now, what is vasculitis? What is vasculitis? Coming to the histological triad. There are three main manifestations. One is there should be leukocyte infiltration. Now, it need not necessarily be all the times leukocyte. It could be a neutrophil as what I've shown here. It could be an eosinophil, or it could be a lymphocyte. At times, it could be a non-leukocytic infiltrate. It could be a plasma cell. It could be a monocyte, or it could sometimes be a macrophage cell. So depending on the type of cells that infiltrate the vessel wall, that's very, very important. Nothing else. There's no infiltration of inflammatory infiltrate from the surrounding areas at all. The second most important characteristic is histologically fibrinoid necrosis, fibrin deposits. There's fibrin deposits in the vessel wall, very close to the vessel wall. And even when you look at it, I've showed it to many of my residents, when you look at this fibrinoid necrosis, a smudge appearance, a pinky smudge appearance of the vessel wall will be made out. And the third very important thing is thrombus with vascular. Now, you quickly recall what I told you in vasculopathy. The main thing is a thromboembolic phenomenon causing obstruction in a vasculopathy. Here it is only one of the manifestations. Now, how does this take place? Let me give you a short summary of how this takes place. Once the neutrophil is brought on, starts producing a signal transduction, what we call as a chemoattractant-induced signal transduction. Now, with this transduction, there is adherence of neutrophils. The neutrophils start sticking to one another. They start sticking to one another. That is what is known as the integrin-mediated neutrophil adherence. And following that is a cascade of events, mainly involving the myeloperoxidase system. That's why when we talk about an inflammatory stance of vasculitis, which is being treated by non-steroidal anti-inflammatory drugs. Now, most of the time we treat vasculitis with steroids, but when we treat them with a non-steroidal anti-inflammatory drug, and I won't say the commonest, but what is most favorite to me is colchicine. When I use colchicine, the next thing that I use is dapsone. Both colchicine and dapsone act at this level of the myeloperoxidase hydrogen peroxide halide system. So what happens is, once this is taken care of, the inflammatory reaction actually reverses and retraces its path, giving on to a normal leukocyte. We call as the respiratory burst. So just to give you a brief summary of what happens in the vessel wall. And further to that, how occlusion takes place and how there could be a complete compromise of blood flow to a particular organ, not necessarily the skin, to all other organs also, is shown here, which could start with adhesion molecules, go on to cell externalization, which is manifested as purpura, followed by vessel calcification, which leads to either atherosclerosis or an aneurysm formation, and finally a thrombotic occlusion. Then we heard Professor Manoharan tell us that we usually classify them depending on the type of vessel wall that is involved. Yes, we can do that. But we must always understand and keep in mind the fact that there could be an overlap. This is just to show you examples of how a small vessel, a medium-sized vessel, or a larger vessel could get involved. And most of the time we don't get to see, as dermatologists, we don't get to see the large vessels except the giant cell arthritis. But there could always be an overlap. And then there are certain conditions in dermatology where there is no predominance of the vessel that is being involved. Absolute no predominance at all. With that non-predominance, particularly conditions like Behçet's disease, which we see, although not commonly, we get to see at least 1 or 2 cases per year. Relapsing polychondritis, Kogan syndrome, where the ear and eye get involved. I'm sure rheumatologists are seeing it more frequently. It goes up to the rheumatologist. But still, there are certain things which are unclassified and do not fit into this small vessel, medium vessel, and large vessel. This is another way of looking at the different types of the girth of the blood vessel that gets involved. Now, this I thought is important because the rheumatologist, nephrologist, and dermatologist interface comes in here. How these small vessels, medium vessels, and larger vessels correspond with the kidney, and what is this renocutaneous analogy that I'm talking about. Now, if you take the kidney and look at the larger vessels, here, for example, the renal artery, the aorta. Now, they will correspond to the larger vessels in the skin. Whereas if you look at the arcuate artery or arcuate arteries in the kidney, they will correspond to the subcutaneous vessels, which we mean medium vessels. And when you look at the interlobular and the interlobar blood vessels, they will correspond to the cutaneous small vessels that we keep talking about. So that is why so frequently, even in children with enoxamin purpura, you get renal involvement, and you want to rule out renal involvement. Most of these patients with vasculitis, with simple vasculitis like enoxamin purpura, we want to make sure that there is no renal disease. The need for that is because of this renocutaneous analogy that I'm talking about. Okay. Luckily, you didn't fix it inside the zip. Huh? Okay. Now, this is just a quick classification of vasculitis. I will go into this deeper in the subsequent slides. Now, why this rational approach is important when we are talking about vasculitis, particularly when we are talking about cutaneous vasculitis. Patients could present with protean clinical manifestations with a wide spectrum, just ranging from isolated cutaneous vasculitis to multi-system involvement. That's what we spoke earlier itself. Several medical conditions can mimic the presentation of vasculitis with a broad range of differential diagnosis. Vasculitis could be primary or secondary. It becomes important to differentiate them because the treatment will obviously change. And there are several different forms of vasculitis. Some are benign and self-limiting, while others have potential to threaten vital organs, particularly the limbs, particularly the lower limbs, leave alone other vital organs like the kidney and the lung. But the lower limbs themselves could affect it in such a bad way, the photographs of which I'll be showing you very soon. Now, with regard to clinical manifestations, a number of non-clinical manifestations are noticed, particularly ear fever, night sweats, etc., which is so very common, even anemia and leukocytosis, which come with so many other conditions. Isolated systemic manifestations pose a diagnostic challenge. I'll be showing you where an isolated systemic manifestation, we had to work up, and of course, as I frequently tell my residents, the eye doesn't see what the mind doesn't know. So that's one of those things which you must keep in mind when a systemic manifestation is brought to you in a skin outpatient department. However, conversely, systemic inflammatory response is not seen in most patients with localized forms of vasculitis. So anything could happen. So one must keep one's eyes and ears open all the time. Specific manifestations will depend on whether there is thinning of the vessel wall or whether there is narrowing or complete occlusion of the affected blood vessel. Thinning of the vessel wall obviously will cause extravasation and purpura, whereas narrowing or occlusion would obviously lead on to ulceration, necrosis and ulceration, in that order. Now, what I will be doing in the next few slides is I shall put the systemic vasculitis syndromes, the different types of syndrome, with the common presenting features. And in the next half a dozen slides, I'll be putting the manifestations first and seeing how it corresponds with the type of systemic vasculitis that we are talking about. For example, in cases of hypersensitivity vasculitis, as in the case of enoxamin purpura, the most important manifestation is a palpable purpura along with arthritis, glomerulonephritis, intestinal ischemia. The child is always brought with a palpable purpura, very, very easy to make a diagnosis of palpable purpura. But the child is brought holding the abdomen with severe pain, intestinal ischemia is there, severe abdominal pain, bloody stools, and difficulty in walking. Arthritis will be there, arthralgia will be there. That is the point of time when you should be able to make a diagnosis of inoxaline purpura. Biopsy is not necessary at all at that stage of the disease. But for academic purposes, I have done biopsies of inoxaline, at least 100 cases of them at the Child Trust Hospital, where we have been able to demonstrate the immunoglobulins. But that is only for academic purposes. Now, in case of cryoglobulinemia, particularly in secondary syphilis, the forms of vasculitis that you get in cryoglobulinemia would be just the same, except that in addition to that, we have the Raynaud's phenomenon in cryoglobulinemia, and how to detect this I shall be telling you shortly. Now, polyarteritis nodosa is a medium vessel vasculitis, where you could get different forms of manifestation, particularly on the skin in the form of livido reticularis, which has to be differentiated from reticular lividoid, which I shall be shortly telling you. Microscopic polyangiitis, where always there is involvement of the respiratory tract in MPO, that is in microscopic polyangiitis, in Church-Strauss syndrome, and in Wegener's granulomatosis. In all these three conditions, you will find pulmonary infiltrates to be present, and in some of them you will find raised eosinophil counts. Kawasaki's disease is another property of the dermatologist, and we always share it with the pediatrician, where you get an exudative conjunctivitis along with, I always keep saying, because I have seen these cases along with Kawasaki himself, where Kawasaki has shown me the drop in the systolic pressure. Just a rapid drop in systolic. An ill child brought with fever, edema of the hands and feet, mucocutaneous eruptions, which you all the time tend to think of a drug reaction. But when we look at the BP, as we keep measuring the BP, quick drop in the systolic pressure, which gives a sign of Kawasaki's disease. Giant cell arthritis, again, not very common, but always seen with a huge, large blood vessel over the forehead, and most important is this polymyalgia rheumatica. Now, this PMR, polymyalgia rheumatica, where there is proximal involvement, proximal muscle involvement, severe pain. PMR syndrome is one thing, always associated with giant cell arthritis. The other condition, of course, you know, is associated with dermatomyositis. But when you get a blood vessel involvement with this type of proximal muscle weakness and pain, always do think of giant cell arthritis. Tachycardia disease, where the pulses are not felt at all. Now, if you were to look at it in a different way, as I told you, the conditions, I just quickly go through them, the conditions where you can get palpable purpura, skin ulcers, depending on the size of the blood vessel wall that is involved, gangrene in an extremity. So these are different manifestations that you would get both as on the skin as well as systemic manifestations, which I have enlisted here. And most of the time when pulmonary involvement is there, there are only these three conditions which you must keep in mind. That is microscopic polyangiitis, Wegener's granulomatosis, and Church-Strauss vasculitis, where in addition to pulmonary infiltrates and cavities, you will also get eosinophilia, peripheral eosinophilia. That's very, very important to differentiate these two conditions from Church-Strauss syndrome. Peripheral neuropathy involving the small arteries, you don't get to see quite frequently in the form of vasculitis. You get to see them in the type of disease where there is mononeuritis multiplex. And the common disease that we get to see with mononeuritis multiplex is leprosy. Leprosy is the commonest thing that we get to see with mononeuritis multiplex, where small arteries get involved with sensory impairment. And of course, stroke again with large arteries with giant cell arthritis. Show you some pictures of certain forms of simple vasculitis as well as the most severe forms of vasculitis. Any one of you could easily make a diagnosis of inoxaline purpura, where the purpura is palpable, and I shall show you in the next few slides how you differentiate purpura from just an erythema. Because quite often we always say a diascopy. Everything will blanch with diascopy. Everything will blanch. Even a purpura will blanch. But what is the degree of blanching is most important, which I shall show you now a few slides away. This is a classical case of vasculitis again, where you can get a manifestation as urticarial wheals. Urticarial vasculitis. The points to differentiate, all of you know, conventional urticaria from urticarial vasculitis. Conventional urticaria is itchy, urticarial vasculitis is tender and painful. Congenital urticaria goes away within 6 hours. Urticarial vasculitis remains for about 48 hours. Conventional urticaria will disappear and reappear at different sites. That's a very important point for you to make a diagnosis. Whereas urticarial vasculitis will disappear and reappear at the same sites, because that's where the vessel wall problem is. So it will occur at the same sites. Further examples of urticarial vasculitis. Here is a case of urticarial vasculitis, a suspected case of urticarial vasculitis, which showed ANA positivity, obviously a case of systemic lupus erythematosus. Or erythema multiforme, again, which could manifest to start with as urticaria, because we have a long list. My residents will be able to tell a long list of differential diagnosis of urticaria. If not urticaria, what else? In that, drug reactions in erythema multiforme come as a very, very important manifestation. Still's disease, the juvenile rheumatoid arthritis. Further cases, as I told you, I'll be showing you, almost everything on the leg will blanch. Almost everything on the leg will blanch. I've tried to demonstrate. But what happens is, in an erythematous lesion, the blanching, the degree of blanching, almost white, completely white, whereas you look at a purpuric lesion, it does turn white around. But on the lesion alone, that pinkish coloration would persist. I'll show it to you once more. Look at the previous slide. Everything blanches. Whereas in the case of purpura, the surrounding area will blanch, but the purpura alone will stand out, as you could see in this patient. Yeah, examples of livido reticularis and examples of reticular lividoid. Now the difference between these two conditions, in livido reticularis, the circles of the reticular network is very well made out, whereas in lividoid patterns, they are not made out. They are broken circles. They are incomplete circles or broken circles. Now that gives us a good differentiating point, because you can get lividoid patterns in so many other forms of vasculopathy. Whereas livido reticularis, when you get perfect circles, the circle is complete. It is only a case of medium vessel involvement, which could be a form of vasculitis, and most often you know what the medium vessel involvements are. Further examples of livido reticularis that could occur, and here it is reticular lividoid, where the circles are not made out, they're all incomplete. Now this happens more commonly in vasculopathies, particularly in diabetic vasculopathy. In diabetes, these are all patients of diabetes, where vasculopathy does occur. It could occur in the form of a lividoid pattern, or sometimes they could be confused with the type of purpura, dermatological purpura or the Schamberg's purpura that we keep talking about. But I always keep telling the differential point between stasis eczema, purpura of dermatological origin. Always, the differential points are very, very simple. In the case of vasculitis or a stasis vasculitis, what happens is upper border is definitely made out. Whereas in the case of Schamberg's purpura of diabetic origin, the upper border will not be made out. It will just be an irregular upper border, as what you see here, This is a fixed cutaneous eruption or a fixed drug eruption, where again mild forms of vasculitis are known to occur. Further cases of diabetic lividoid vasculopathy. Here is a case of nodular lesions which we get to see in erythema nodosum, which is always associated with vasculitis. Now this is something which all of us should keep in mind. Whenever we see erythema nodosum, or whenever we talk about the histopathology of erythema nodosum, we say the basic pathology is panicolitis. What is the type of panicolitis that you get? The type of panicolitis that you get there is a septate panicolitis, which has to be differentiated from a lobular panicolitis, which we get in Erythema induratum, Bazan. In Bazan's disease, you get a lobular panicleitis, whereas you get a septate panicleitis in erythema nodosum. Again, it is important for us to differentiate two different forms. One is lobular vasculitis or lobular panicleitis with vasculitis, and lobular panicleitis without vasculitis. When you get it with vasculitis, it's erythema induratum. Similarly, when you get septate panicleitis with vasculitis is erythema nodosum. Septate panicleitis without vasculitis is Weber-Christian's disease. Weber-Christian's disease. Please do remember. But these are some small questions that may creep up by the examiner, from the examiner to us during a viva voce. So with vasculitis, without vasculitis, what is the type of panicleitis? Whereas a mixed form of panicleitis you get in lupus panicleitis. In lupus panicleitis, both lobular and septate panicleitis. Examples of erythema nodosum which you could get. Here is perniosis. Here is perniosis which you get again as a manifestation of diabetes, and a vasculopathy. Vasculopathy. So if you do a biopsy, you will not see the vessel wall getting infiltrated at all. You'll find only a block. You'll find only a block. This is a nice example of a case where a palpable purpura was present, but didn't end up to be the usual Henoch-Schönlein purpura that we think of. Because whenever you get a palpable purpura, there are three important conditions that you must always keep in mind. One is a leukocytoclastic vasculitis. Number two is vasculitis associated with drug reactions, and then your Henoch-Schönlein purpura forms of vasculitis. This might be belonging to some of the other form rather than the Henoch-Schönlein purpura. When we spoke about vasculopathy and when we spoke about purpura and the types of purpura that could occur, there's one type of purpura where you get purpuric ulcerative lesions with a reticular pattern over the lower extremities. Purpuric ulcerations, lower extremities, reticular pattern is given the acronym purple syndrome. Purple syndrome, P-U-R-P-L-E, purple syndrome, which again is associated with diabetes. Painful, very, very painful. So you get painful ulcers with a reticular pattern over the lower extremities. Yet another example of the purple syndrome. This is a straightforward case of drug reaction leading on to erythema multiforme. Yeah. This is an internet photograph. This is an internet photograph, not my patient's. You can't miss it. What's it? Sorry? Yes, giant cell arthritis or the temporal arthritis. Now we'll keep this as a prototype for the next few seconds. Look at this. Now this is a nun sister who walked into my OPD. A nun sister who walked into my OPD with this type of a purpuric lesion over the lower limbs, having a mild reticular pattern, Very, very healthy girl, lady she used to be. I use the word term because she used to come to use the term girl because she used to come to me as a very young girl, the nun sister. And then when she was around 40 or 45, mid-40s, she came in recently. Recently means about 2 years ago. She came in with the type of lesions. And she also had a left-sided hemiparesis. So I was trying to figure out what this is all about. She's a very, very, great amount of faith in me. She always comes to me for a treatment for any minor skin problem also. Had a very, very close look at her. I hope you guys are able to appreciate this vessel, dilated vessel here. We did a biopsy, and it turned out to be a giant cell arthritis, and we had to treat her with cartloads of steroids. So that's what I told you. When you always keep in mind the possibility, now that you have a spread in the menu, all you have to do is select according to your taste and according to what suits your system, what you have seen as signs and symptoms in the patient. Now you have a menu to select from. You have to select the type of vasculitis and treat accordingly. And the forthcoming slides you will see that I will be telling how you start differentiating them with the signs and symptoms. Of course, here is the statement I have made very clearly. Livedo reticularis differentiates cutaneous polyarthritis nodosa from adult forms of Still's disease, where you could get rheumatoid arthritis. You must be able to differentiate this. Now here is a case of Church-Strauss syndrome, classical palisading granuloma. We always talk about histological palisading granuloma, which is coming up in the histiocytic disorders. When we talk about granuloma annulare, when we talk about necrobiosis. But here is a clinical, what we call as palisading granuloma in the elbow in Church-Strauss syndrome. This is so much of glossitis, so much of erythema and purpura. Kawasaki's disease, and this, you get cheilitis, conjunctivitis, urethritis, you find the positive pathology test. Behçet's disease is published by Dr. Sindhu. She's here. Sindhu and I had published this case of Behçet's disease. This I borrowed from my good friend, colleague, former student, Professor Parimalam. Pyoderma gangrenosum healing up with scarring, known to be a form of vasculitis. Now some infections, particularly viral infections of the nature of herpes zoster, known to end up in a vascular embolic phenomenon, a thromboembolic phenomenon leading on to gangrenous changes. So never leave herpes zoster as a simple condition. Make sure you start treating. And most of my residents will agree with me, I always treat my herpes zoster patient with a small dose of steroids, for more than one reason. Number one is the vasculitis will be taken care of. Number two is the ganglionitis, which is known to occur in herpes zoster, will also be taken care of. As a result of which, the incidence of PHN, or post-herpetic neuralgia, is very much reduced. I'm sure anybody who tries it will agree with me. Small doses, 5 to 10 milligrams of prednisolone orally, along with your antiviral drug, definitely brings down the incidence of post-herpetic neuralgia, because not only the ganglionitis, but also the vasculitis is reduced. We'll go to a little bit of theory for a short while now, for the next few minutes. 5 important questions to ask whenever we are faced with a case of vasculitis. Is this a condition that could mimic the presentation of vasculitis? Is there a secondary underlying cause? What is the extent of vasculitis? How does one confirm the diagnosis of vasculitis? What specific type of vasculitis is this? Now I'll quickly go through the answers for this, because there are more than one cause where we have to think of, particularly as I told you, infections. Infections is one thing which will be a great mimic of vasculitis. And there's one easy laboratory test, although it's pretty expensive, easy laboratory test. All you have to do is do the procalcitonin level. This is an important, it brings down, it shows whenever there is sepsis, procalcitonin level is increased. So if you do this, you'll be able to differentiate an infective cause from an inflammatory cause. Proper history taking are very, very important, along with certain other investigations. And please don't forget, when you're dealing with women today on Women's Day, a woman who comes with repeated attacks of vasculitis, with a livedo reticularis pattern, and with recurrent stillbirths or recurrent abortions, please rule out antiphospholipid syndrome. Do the apply antibodies and rule out antiphospholipid syndromes. Then what is the extent? What is the extent of vasculitis? What is the amount of systems that are involved? Is it just the skin alone, or is it the GI tract, lungs, and liver? These are the things which we must be very careful about. As I told you, kidney, needless to say, the renal-cutaneous analogy that we spoke about. A good amount of laboratory investigations, which I shall be enumerated in this particular slide, where you will have to go through, particularly when you are thinking of a secondary syphilitic pattern or a syphilite pattern. Cryoglobulins have to be looked into. Another important thing that is coming into vogue nowadays is this anti-neutrophilic cytoplasmic antibodies. Our friend the rheumatologist will agree that almost for all patients they'll be doing an ANCA, and it's worth the trouble, worth the money, an ANCA study. I should show you a line diagram of how ANCA does help. Histological confirmation, as I told you, when you see vasculitis or when you see pancreatitis, try to correlate these two conditions. For instance, if you find, again I repeat, if you find only a septate pancreatitis without vasculitis, please keep in mind the possibility of Weber-Christian disease with vasculitis, erythema nodosum. When you get lobular panniculitis without vasculitis, please keep in mind the possibility of lipodermatosclerosis, LDS, lipodermatosclerosis with vasculitis, erythema induratum. A combination of all these three with a mixture of this, you always think of LE profundus. So histological confirmation as well as certain amount of radiological investigation and MRI also has to be taken care of. And then we have to find out the specific type of vasculitis that we are dealing with wherever possible, depending on the clinical manifestation. This is a very, very busy slide which I wouldn't want you to go through. We look at only certain important aspects. I've put here 3 columns where there could be only cutaneous manifestations, and there could be, along with that, certain other systemic manifestations. I separate them. Only the cutaneous manifestations. You take the first 3 of them. Always think in terms of cutaneous leukocytoclastic vasculitis. In addition, if there is intestinal ischemia, think of Enoch-Charlene purpura. Now, if none of them are there and Raynaud's phenomenon is added on to that, your cryoglobulinemia, as I told you earlier. When you find the other 5, peripheral neuropathy, mononeuritis multiplex, renal ischemia, testicular pain with livedo reticularis, you think of polyarthritis nodosa. PAN has to be thought of. When there is systemic involvement, particularly the lungs getting involved, please do remember microscopic. I told you there are 3 conditions only with pulmonary involvement and vasculitis. Your MPO, that is microscopic polyangiitis, Wegener's granulomatosis. But along with that, when you get the other manifestations, particularly with coronary artery disease, please rule out Church-Strauss disease. Other manifestations, systemic manifestations, depending on their presentation, you could think of Kawasaki's disease, Takayasu's disease, or a giant cell arthritis. This is what I told you. I'll tell about ANCA, the ANCA positive and ANCA negative. Where always when you see a vasculitis, please do an ANCA whenever the patient could afford it, because it's worth the trouble. We're not able to get a clinical diagnosis. This is too crowded. Look at this. When it is ANCA positive, and depending on whether it is a P ANCA, when I say P ANCA, I mean a perinuclear ANCA. When I say a C ANCA, I mean a cytoplasmic ANCA. Look for P ANCA and C ANCA. When you find a P ANCA positive, and look for eosinophils in the necrotizing vasculitis in the vessel wall. If it is present, as I told you, eosinophils present, Church-Strauss syndrome. Eosinophils are absent, you think of MPA, microscopic polyangiitis. But if you see a C ANCA, that is a cytoplasmic anti-neutrophilic cytoplasmic antibody, you think of Wegener's granulomatosis. These are some conditions where ANCA will be positive. Now, when you find ANCA negative, search for cryoglobulins. It's very, very easy to do cryoglobulins. All you have to do is take the serum of the patient, dip it into ice water, and it precipitates, then cryoglobulins are positive. Look for cryoglobulins. If cryoglobulins are positive, you are dealing with the case of cryoglobulinemia. If they are negative, immediately start looking for IgA in a direct immunofluorescence. IgA is present, you're looking at HSP, Enoch-Charlene purpura. If your IgA is negative, then it could be a cutaneous leukocytic vasculitis, or it could be a polyarthritis nodosa. So this is very, very easy with the ANCA positivity and ANCA negative, with a few accessory tests, with a few additional tests to differentiate these conditions. I've just repeated that slide. So physical examination, ladies and gentlemen, becomes first and must. Particularly, certain things are done as a rule. But this I don't think all of us do. Break the ankle ratio, blood pressure is important. It's very, very simple, bedside clinical examination that you do with the brachial artery and with the femoral artery. Because when you see the ratio, the normal ratio is somewhere ranging from 0.8 to 1.2. Please make a note of it. It's important. 0.8 to 1.2 would be a normal ratio. Now, anything more than 1.2 means that there is hardening of the vessels. please remember, more than 1.2, it is hardening of the vessels. Whereas if it is less than 0.8, particularly reaching towards 0.5, it means there is narrowing of the vessel. Now, why is it important for us to differentiate these two conditions? When there is hardening of the vessel, particularly in the lower limb, it means when there is hardening of the vessel, you can treat it with a compression bandage, elastic wrap bandage. Very well afford, the patient would very well afford to use this. Whereas when there is an obstruction that is less than 0.8 going on to 0.5, you are not supposed to use a compression bandage. You cannot use an elastic wrap bandage. So with a simple blood pressure examination, I don't even see my residents carrying a stethoscope nowadays. When we were postgraduates, I'm sure Manogar, Jayakar and all of us, we always used to have the stethoscope around our necks. They never found my residents go around with a stethoscope nowadays. It's very, very important, very, very important. As dermatologists, they think only using a flashlight, that too which has been given by somebody else. A flashlight is being used around. So be careful. Peripheral nerve examination, time and again we keep telling you guys to examine. Doesn't matter if you're not able to see the other systems, because that we can depend on the general physician. Sometimes we can't depend on general physician also. We have seen outpatients tickets come even without the BP being recorded. But it doesn't matter. So we will do our job correctly. Number of pitfalls in diagnosis is there, particularly when you do a skin biopsy. As I told you, you have to be extremely careful. See again, see once again, and see for the fourth time. Not only for vasculitis, for all conditions. Even recently, we were able to detect a case of Bowen's disease, a case of arsenicosis, by repeatedly seeing the slide, repeatedly seeing it. So keep repeatedly seeing the slide, see at deeper levels, ask for sections, deeper sections, and see carefully and examine. Management, steroids, sheet anchor. Steroid sheet anchor, bed rest of course we give. And as I told you, a very favorite drug for me is colchicine. I don't know whether Dr. Rajshekhar will agree. Colchicine is my very, very favorite drug. Next I go to dapsone. I don't much depend on the other immunosuppressants. But what I try to do is look at the other drugs that the patient takes, particularly if the patient is on an anti-diabetic. I try to tell the diabetologist, change that drug. The gliptin is not agreeing with the patient, please change it. If the patient is a hypertensive, please change. Maybe it is not the beta-log or the metoprolol which is helpful. Change it to something like ismalol. Ismalol is a very, very recent drug which is used usually inside the theater only, operation theater. Change it to some other drug which is safer for the patient. So keep those things in mind in the management. The symptomatic and non-specific measures, of course, might help to a certain extent, particularly when there is organ involvement. And vasculitis is one condition, ladies and gentlemen, where there is a multi-system or a multi-specialist involvement with which only we'll be able to make a diagnosis and treat. So what would be the conclusion of this session? Patients whom vasculitis is suspected need detailed medical evaluation. We need the help of an internal physician. We need the help of a nephrologist. We need the help of rheumatologists, and these are the people who are going to really delineate conditions from us. It is particularly important to recognize ANCA. I want to repeat this, ANCA to be done. It is a little on the expensive side, but it's worth the trouble. It's worth the trouble. Quickly you can rule out 3 conditions when it is ANCA positive. And when it's ANCA negative, again, you just follow the algorithm that was given. It's very, very useful. And to finish off, I have to tell you, the more it changes, the more it is the same. So keep reading your books repeatedly. You'll find that although edition after edition it changes, the primary things or the basics will not change. The circle of Willis that I read or my grandfather read still remains the circle of Willis. That doesn't change at all. So the basics will remain the same. So be very, very careful, very, very sure of your basics. The circle of Willis is still the same. When you look at dermatology as such, the price curve will still remain the same. It does not change. The gray cells and the light cells or the dark cells which are present in the eccrine glands remain the same always. They are not going to change. Only the content and what is the chemical content of these granules that are present might change. But the appearance will not change. So the more it changes, the more it is the same. Thank you very much for your attention. Thank you, Chairpersons.